Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Well, let's get started then. I think we have an exciting topic here today, one that I'm looking forward to sharing with you all. It's entitled, of course, Hip Pain in the Young and Middle-Aged Adult, A New Understanding and New Treatment Strategies. And the idea here is that as physicians, we now know something about the hip that we didn't know 10 years ago. And over the last 10 years, we've refined what we do know, we've come up with treatments, and now we have some good outcomes data that show that those treatments work in the long term. So it's a rare situation when we get to really offer a whole new field of understanding and a whole new field of treatment to a patient. That's what we're doing here today. So I hope you find the talk enjoyable. So just to go over our basic outline, essentially I'll introduce some topics early on. We'll go over some basic anatomy. We'll talk about what we used to know about the hip and kind of do a little straw poll about what can go wrong in the hip. And then we'll talk about what we're here for today. You know, what did we learn recently as a medical community? And what are the new diagnoses we have for the hip? How are they treated? And how do folks do after that treatment? So I like to start things off broad. This is not our average patient in the clinic, don't worry. This basically is just our old caveman here. What I'm trying to point out is that humans have been exploring and pushing the envelope ever since we walked on 2 feet, and even before. We build tools, we see what's around the next corner. Most days are pretty mundane with small achievements made. However, there are banner days, there are watershed events. Columbus discovers the Americas, man walks on the moon. And my point here isn't that these things happen. My point is that rather than that these days are impressive in and of themselves, these days represent the opening of a new chapter. And the big watershed event in what I'm about to discuss happened about 15 years ago. And now we're at the point where enough of that next chapter has been written that we can appreciate the advances that have been made. We've discovered things. We've done our Lewis and Clark expedition after Columbus discovered the Americas, and we really understand the lay of the land now. So it's a great time to be a patient and a great time to be a doctor. Now these advances that happen in steps are also true in medicine and orthopedic surgery specifically. I'm showing you on the left here a rod in a nail, a rod in a femur. That's something that we didn't have until World War II when physicians first started using it, and now it's part of commonplace orthopedic practice, but it was a completely new technology back then. What you see on the right here, this is an image of arthroscopy, specifically arthroscopy of the hip in this case. And I wanted just to take this moment to describe what arthroscopy was and how that's a technology that we've had for a couple of generations now, but it's one that has become quite common in orthopedics. Arthro means joint, scopy basically means to look. So arthroscopy is looking inside the joint. We don't just look inside the joint with the little camera here. We also work inside the joint through little instruments that we put in. In the olden days, what we used to have to do to get into a joint was make a large incision, cut through whatever's between the skin and the joint, push it out of the way, and then take the joint out of place and look at the cartilage, look at the bones, and do what needed to be done. But with arthroscopy, you can make small incisions, pass instruments and a camera inside the joint, and basically work from the inside out, which sometimes makes the operation easier, believe it or not, and certainly makes the recovery a lot easier for the patient. Now, hip arthroscopy is something that we've just started to really get our head around in the last decade, but it's a very exciting field. And the advancement we're going to be talking about today isn't just hip arthroscopy, but our understanding about what goes wrong in the hip that then warrants hip arthroscopy. Now, I'm going to try to make the argument here that we don't know much about the hip in terms of what the lay public is aware of and actually what most primary care doctors are aware of. And the truth is, at least as of a couple years ago, what the average orthopedic surgeon was aware of, because this really has developed quickly. If I asked you guys to do a straw poll, like I alluded to before, and said, please tell me something that could go wrong in the knee, I don't think folks would have much difficulty. You would cite things like a meniscus tear. You probably had a friend with one of those. And patients come to my office with all these things frequently. You might have a fracture. You might have an ACL or other ligament tear. You can get arthritis. You can have cartilage defects. You can have kneecap, also known as patellofemoral pain. The shoulder is kind of the same thing. There's a fair number of things the public is familiar with that can go wrong in the shoulder. We can all get rotator cuff tears, tears of our labrum. The shoulder can dislocate. You can get arthritis of the shoulder as well, and fractures about it also. And there's a phenomenon called impingement, when the shoulder can be painful when reaching overhead. Now, by comparison, let's look at the hip. If I asked you all to make a list of what can go wrong with the hip, and you hadn't read any of the materials that were handed out for this talk, I suspect the list would be shorter. It certainly would have been for me a few years ago. We talk about how the possibility exists to have arthritis. You can also have a fracture about the hip. That's typically something that occurs in the geriatric population and is not very subtle and almost always requires surgery. Other things you can get are muscle strains. But I think beyond that, we'd have a hard time coming up with what else can go wrong in the hip. So someone comes to the doctor, and this could have been me 5 or 6 years ago, or it could have been another physician 5 or 6 or a couple years ago. And someone comes in with an x-ray that looks like this, and they have hip pain, and they're young or middle age, and the question is, what is it? What's wrong with them? The doc may say, because we're working with limited options here, we don't know a lot about the hip yet, oh, this is early arthritis, it's just not showing up on x-ray yet. Or there's some subtle childhood deformity that's causing some pain, but we don't really understand why that is the case, and there's not a whole lot we can do about it. But that all changed. About 10 or 15 years ago, a small group of orthopedic surgeons that specialized in the hip started delving deeper into this, doing studies and following patients. And a lot of these physicians were actually in Europe, Switzerland specifically. In the last 5 years, we've really taken a big step in refining our understanding of what can go wrong in the hip and our treatments of it. And what is exciting, and what I'll get to later, is just recently, in the past year, we've had our first outcome data showing good 10-year results after the treatments that we offer for these sorts of problems. So the reason I'm giving this talk is here. Patients have been having problems even before we knew what the problems were called. So I think what's going on is that there's a backlog of patients that have occurred over the last 30 to 40 years that are still in a window that we could treat for diagnoses that we didn't know about until the last 5 or 10 years. And I'm giving this talk in an effort to inform the public, inform other physicians in the area that there's treatments available now. And that if you've had pain and it hasn't been able to be diagnosed in the past, the possibility exists that it may be able to be diagnosed now, and it's worth giving it a second look. Just to further show you how this has really blossomed here, when you look at hip arthroscopy, which is one of the main treatment modalities for the diagnoses that we'll be introducing in a moment, there really wasn't much discussion in the 80s and early 90s, just one article a year. It started coming up to speed here, and then we were in double digits in the mid-2000s. And if they had gathered the data from 7, 8, and 2009 as well, we'd see another jump in 2008. And I think these numbers are up in the 30s now. So here's our punchline. What are these new diagnoses? Well, they're listed in yellow. Certainly, patients can still get arthritis, fractures, and muscle strains. But there's a new diagnosis. This is the main one we're going to focus on a lot, called femoroacetabular impingement. Like most medical diagnoses, it's a mouthful, and I don't know why they make it so complicated, but we're going to break down this word, and it's not going to be very complicated. Essentially, what it means is the femur, which is the ball, and the acetabulum, which is the cup, are impinging or hitting on each other. And when that happens, things get crunched in between. Those things are the labrum and the cartilage, and they can have subsequent tears or delamination, which basically means peeling off. And that can all be secondary to this impingement here. We'll also briefly touch on the phenomenon of snapping tendons at the end of the talk, which is a slightly different but somewhat related topic. So I like to start with anatomy. In my mind, discussing the anatomy is like showing you a roadmap of where you're going to be going on your trip. To start off very generally, the hip is a ball and socket joint, as we all know. This is the femur, which is your thigh bone. It comes all the way up to your groin, and it articulates with the cup, which we call the acetabulum. The way you can help remember the word acetabulum is you may all have heard of vinegar. The real word for vinegar is acetic acid. Acetic acid is so named because wine, the root for the word wine is aceta. And when wine goes bad, it turns into vinegar. So vinegar is basically wine acid. So acetabulum, tabulum basically means goblet. So acetabulum is your wine goblet. That's basically where the word comes from. So that'll help us remember the term. You see here, this is the femur ball and the acetabulum there. And we get into a little more detail. We see there's a rim of cartilage around the outside called the labrum. And we'll look at that a little bit more here. This is a view looking right down on the cup. The ball has been removed. This is a picture, not a real patient. And you can see there's this nice horseshoe shape of cartilage. I want to take this moment to describe what cartilage means. Cartilage is different than bone, and there are different types of cartilage in the body. It turns out that the labrum is also made of cartilage. But this here is articular cartilage, or hyaline cartilage, as they call it here. And what that is, that's the shiny, smooth, kind of bluish-hued cartilage you see basically at the end of a chicken bone when you're eating that. You know, it's part of the joint. It's what lines the joint. It's as smooth or smoother than ice, and it helps our joints glide. And this is the cartilage on the socket part of the ball and socket hip joint. The labrum, as you see, is this little O-ring, if you will, around the outside that helps offer a little bit more support to the hip and perhaps some cushioning around the edge. So let's talk about what femoroacetabular impingement is. We've already broken down the word, and let's try to understand what it means. I'm going to start talking about what it's not. But what it's not is something we may all be a little bit more familiar with and something we can draw an analogy from. Can anyone please raise their hand if they've ever heard of hip dysplasia, if that is remotely familiar? Okay, so I'd say about a little over half of our folks here. That's good. Hip dysplasia, that's what this shows here. That's when there's not enough coverage in the hip. This socket here, the cup, really isn't going over far enough. It leaves the ball kind of uncovered, and that's not good because it leads to early arthritis. This is something we diagnose in children, or we like to, and we can treat it early, and there are excellent treatments for that. We may also know that a lot of dog breeds are susceptible to this, such as German Shepherds, and I suspect some of the folks that raised their hand might have been familiar with it from that setting. Well, the analogy I'm going to draw here is Goldilocks. This here is too little. One of the forms of femoroacetabular impingement is when you have too much coverage, and that's not good either, because while this leaves the hip uncovered, too much coverage leaves it over-covered and makes it so when you take your hip through a range of motion, the ball hits up on the socket rather than gliding smoothly. So Goldilocks didn't like too little, she didn't like too much, she wanted it to be just right, and that's how we are as well with the hip here. So this is just an image showing the different types of femoroacetabular impingement that we have. We've already discussed how the name makes sense when you actually break down the big words. The two main types are cam impingement and pincer impingement. If you think about it, the femur is bumping up on the cup, so the problem could be on either side, or perhaps both sides. Cam impingement is when the bump is on the femoral side. This is what a femur should look like here in the cup. This is a cartoon drawing. This hashed area is extra bone there. It shouldn't be there. And we'll show some pictures of what happens when it gets flexed up into position, but if you take your mind's eye and rotate this ball through the socket, you'll see that this little hashed part will bounce up on that cup and cause problems. Similarly, down here, this is pincer impingement. The cup is too deep. Rather than having a normal cup here, we have extra bone out front. And as this hip flexes up, there's going to be contact between the two, crunch the labrum, crunch the cartilage, cause tearing, and cause pain. Now those are the two pure forms. The bottom line is that actually most of these cases are mixed. Most folks have a mixture of cam and a mixture of pincer. If they did have pure cam, that's usually in a male patient. If they had pure pincer, that's usually in a female. But this is what we usually see, where there's a little bit of each going on. This is the picture I was alluding to before. This is a hip doing what it does, going through its motion, flexing up nice and high like we do when we go upstairs, when we put our foot on a stool to tie our shoes, or go on a bicycle ride or whatnot. This here is pincer. You start to try to go up there, but all of a sudden, we have contact right here. The labrum sits right there. It's going to get crushed. There's going to be pain, and the hip will actually start to go out of socket somewhat, believe it or not. Not completely, but it'll start to sublux, which means go out of place a little bit. With this cam impingement here, you see a similar phenomenon going on. You start to flex up, and this shaded extra area comes in contact with the rim and causes the same type of crushing and pain. And this is something we didn't know about 10 or 15 years ago. It's something only a handful of orthopedic surgeons were talking about in this country 5 years ago. It's still something a minority of orthopedic surgeons are talking about in this country, but it's one of the hottest topics that gets discussed in our orthopedic meeting over the last year or two. It's really beginning to be appreciated now, and the word is getting out. This is just another image showing similar problems with the pinching in the cam and the pincer impingement. So who gets femoroacetabular impingement, or FAI for short, since the other one is a mouthful? Typically, these are younger middle-aged adults. They're often active because it's the active population that takes the hip to the extreme, puts it up into deep flexion, cycles it 1,000,000 times each day on their long bike rides. But not everyone is active who gets it. If you have a severe deformity, that'll become painful and problematic even with just doing your normal activities each day. And a lot of my patients fit that category. Typically, there's no trauma, no accident, nothing really happened. It just kind of came up out of nowhere. Patients are perplexed. They didn't have a car accident, they didn't fall, they didn't twist anything. It just kind of came up. And that actually makes sense if you think about it, now that you know how this works. Each time you bring your hip up, you're doing this if you have this sort of abnormal anatomy. So it stands to reason that there wouldn't have to be an event. This would just be something that wore and tore over time and eventually became symptomatic and problematic. That being said, there is a subset of patients that do have some sort of twisting and get the ball rolling that way, but that's the minority of folks. Over 9 out of 10 patients have pain when they do activity, but it's amazing that almost half of patients also have pain at night. Things get so flared up during the day, taking the hip through the range of motion, having the pinching, having the tearing, that even at night when their legs are relatively still and not in any extreme position, they actually still have pain then, which can be troublesome because then they can't sleep at night and they're not productive or happy the next day. This is an interesting point about where the pain is. You know, before I became a bone doctor for a living, if someone asked me where hip pain would be occurring, I would have said, oh, right over here. This is the top part of your hip, which is the iliac wings, and we'll show an x-ray in a moment where that is. But the groin down here is actually where the ball and socket sits. And that's where most of our patients actually get pain from this problem. That being said, everyone's different. That's the beauty of medicine. And people will get pain from the ball and socket that could shoot around to the buttock. It could be on the side, or it could be in the front. But the most common complaint that folks have is they'll grab their side and they'll say, it hurts really deep, right in here. And they'll point to that. They'll almost grab their groin here in the front and the back, and they'll say there's something wrong on the inside. And that's what they complain about. Like I said, it's typically intermittent at first, but it gets worse and can become quite problematic over time. So what do we do about that? Someone comes to the office. There's a lot of high technology techniques that we have to look at this, but we start very low tech. We start with a conversation. That's called the history in medicine. We ask patients, what's wrong? Let's describe this hip pain. Is it up here? Is it down here? When do you get it? What's it like? What have you done for it so far? Has it worked? Is it getting worse? Is it getting better? We ask all these questions to try to tease out the complexion of the problem. Then we do a physical exam. It's the best test we can do and still the cheapest, and this is something called the impingement test, which is one of an assortment of physical exam maneuvers we do during any one of these evaluations. Everyone that comes to the office also gets x-rays, and we'll look at those here today. And then in many patients, we end up getting an MRI with some dye and anesthetic fluid injected in as well to help us look to see if there is some tearing in the hip as well. Just as an aside, this is where I was putting my hands at first up here. That's where the hip is, the iliac wings. The hip joint is down here, which is that groin area. So this is an x-ray of someone with femoroacetabular impingement. You might say it doesn't look too bad, but if you look closely, there's a little bump there, and there's a little bump there. This head should be perfectly circular, but it's not. There's that little bump on the outside on both sides, so this person has some of that cam impingement in both of the hips. There might be a little pincer going on as well. To determine if there's pincer, we do some specific measurements. Patients will often see me come into the room and their x-rays have pencil marks on them and angles that are measured out with a protractor and this and that. And this is what I'm doing with that. We measure certain angles to see, exactly how much coverage there is in the hip. We don't just want to eyeball it and say, oh, it looks like too much, you have extra bone there. We want a number that we can compare to what normal is and see if it's too much or too little or what. In some cases, it's quite obvious that there's an issue going on. There's way too much coverage here. We would measure it anyway. And then what's either gone on here is bone has fatigued from being pinched so often and basically started just to fail, some sort of subacute fracture here. Or what can also happen out here is you can get calcification or turning to bone of that labral tissue. If it gets beat up enough, it'll turn to calcium, and that can become painful too because then it's hard and it's not soft and it's prone to tearing once that happens as well. Now, while too much coverage is one of the main problems, misorientation of the cup is another. This is a concept that's difficult to appreciate because x-rays are two-dimensional, but our pelvis is obviously three-dimensional. I'm going to step back for a minute and explain to everyone that the cups in our hips aren't pointed straight out to the side. They're actually pointed forward. And that will make sense to you when you think about it because if you try to move your hip up, you have a lot of room there. If you try to move it back, it hardly goes anywhere. That's because the cups are pointed forward, so there's lots of room to go in that forward direction, but going back, we can basically just get to straight or maybe a couple degrees beyond that. However, let's imagine that someone has a misoriented cup. It's called a retroverted acetabulum. What that can mean is that you end up getting impingement of the ball on the socket here. And the way we look at this is on something called a crossing sign. This is normal here where you have these two lines that don't intersect. But if we draw out those lines and they cross here, it means there's that acetabular abnormality and there's a little bit of extra bone in the front of the cup that's going to block motion when you try to flex that hip up nice and high. This obviously is a donated specimen as there's no person attached to it, but it shows very nicely how you can have this problem on one side of the body and not on the other. If you follow the line here that was drawn out, it's a nice circle and never crosses itself. Here by comparison, it's a figure of 8. You see the cross there. So they do have this acetabular abnormality on this side, but they don't over here. Let's switch gears and talk about cam impingement. I already alluded to what's going on here in the first x-ray we looked at, but basically what it is here is a little seeking out mission looking for abnormal bumps on the femur. Some of them are easy to pick out. This one looks pretty straightforward. I think you guys can all appreciate it. This one doesn't look too bad, but when you flip the hip on its side and look from the other perspective, you can see a little mound forming there. And this one has a subtle abnormality there as well. It can be hard to tease out that this is actually going on, but if you draw circles here that are perfectly round, you can see that bone extends out beyond the circle here and also beyond the circle here. And that's extra bone. That shouldn't be there, and that's going to get in the way when you take your hip through these ranges of motion. But at first glance, you wouldn't suspect there's that much extra bone there. There's without the circles. You put the circles on, all of a sudden it looks like there's a fairly significant issue. And the ball should be perfectly spherical. Another description of the same thing here. This is a normal hip. This is an abnormal hip. The circle's nice and lining up with the ball here. On this one, there's this extra bone in this section here, which shouldn't be there. And when you flex the hip up, that bone is going to contact this bone and cause problems. This is just a picture of mixed FAI. This picture might look familiar. This is one I showed you earlier, trying to illustrate pincer impingement with that bone that had flaked off. But what I'm trying to show you now is when you look closer, there's a little hump here, and that here is that cam impingement. So this, like many, is actually mixed, and you see the bone extending out beyond the circle there, illustrating that. So the bone is important to look at, and x-rays are critical, and we get them on all patients. But a lot of our issues here deal with the labrum or cartilage, and that doesn't show up on x-rays. We have to do more advanced imaging, like an MRI, to get a better picture of that. The picture on the left shows a normal labrum. The one on the right shows a tear. If you look right here, you can see there's actually a little cleft, and you might see some suggestion of a white line there. And that actually is a labral tear. We actually find it difficult to see labral tears oftentimes, and what we do to improve the chances of seeing them, if they do exist, is inject some dye into the joint at the same time, and that dye will run between the tear and the cup, light up on the pictures, and make it easy to see. This just shows some more pictures here. There's a little light hue you can see here. Here's just a little illustration of a labral tear. You can see that it's flaked off here. It can be causing some clicking and catching in the joint sometimes. Patients will have pain when they're sitting, walking, twisting, or doing anything that pushes the limits of the hip. This is another graphical description. This basically is a picture of what one of the MRI cuts would show. It should be smooth here from the cartilage to the labrum, and when there's this break there, that's a labral tear. This can be clicking around and causing pain and get inflamed and be a source of a patient's symptoms and discomfort. Chondral delamination, that's one of the other things we're going to talk about today. And imagine if at the end of that chicken bone, the cartilage was just peeling off. And the analogy I usually draw to patients is, imagine if the carpeting from the side of the room was starting to come up from the subfloor. You know, you start to walk on it more, it comes up more and more, it kind of is rippled there on the side, it's not laying flat, it's no longer adhered to the subfloor. And when you take a hip through a range of motion, that can be clicking back and forth, causing pain, and continue to delaminate just like a hangnail gets worse with time. These things, we believe, can also get worse with time as they extend. And you can see how unstable some of these conditions are here with the probe moving that whole flap of cartilage out of the place, exposing the bone underneath. Sometimes you get lucky and can see this on MRI, but it's almost impossible. Some MRIs are super high-powered, used for research at academic centers, not really used for patient care. When we use those high-powered MRIs, sometimes we can see a subtle signal in here. But pretty much chondral delamination is something we can only suspect going into surgery, and it's something we confirm when we actually look at the joint ourselves and feel it with a probe to see if it exists. Now, this is a key part of the diagnostic strategy. The hip is a tough joint to diagnose. It's deep within the pelvis. It's not right under the skin like the knee is. It's not under a little bit of muscle like the shoulder is. It's deep in there, and there's a lot of different layers that are between the skin and the actual ball and socket. And in some cases, it's tricky to determine where exactly the pain is coming from. So we have a way to tackle this. When we have the radiologist injecting dye in to get a good look with the MRI, we have them mix in some lidocaine, which is like Novocaine, at the same time to numb up the ball and socket. The patients always get instructed, please go into this with some hip pain. Make sure you can reproduce your pain, get it flared up. Then they inject the Novocaine into the ball and socket, and then the patient tries to flare the hip up again. If they can't, because the pain is gone, because it's numbed up, that confirms that indeed we have pain coming from the ball and socket joint, not from some other layer like a muscle strain or whatnot, or a tendon. If they say my pain never got better, then it suggests that their pain is coming from something outside the joint, because the joint is numb and shouldn't be causing pain anymore. And if they still have the pain, it can't be coming from the joint. This pain, of course, only goes away for a few hours, and then the Novocaine wears off. Sometimes we mix some cortisone in as well to try to give longer-term relief. So if someone has a diagnosis of femoroacetabular impingement, perhaps a labral tear, what do we do about it? Well, we always try to start with non-surgical treatment. That's the conservative way to go about this, and it's best to avoid surgery if possible. We try to modify activities. If certain bicycle maneuvers hurt it, we can elevate a patient's seat or do something to try to keep them out of the range of motion that hurts it. We give anti-inflammatory therapy. I already alluded to the fact we sometimes inject some cortisone, or steroid as it's also called, into the hip joint to decrease the inflammation there. We can also do some physical therapy. But unfortunately, for this collection of diagnoses that we're talking about today, the non-surgical treatment is not extremely effective. And I think there are good reasons for that. We try it anyway, because we'd love to avoid surgery if possible, but a lot of these patients are very high activity level and are really pushing the limits and don't give the joint a good chance to rest. Typically, these conditions, like the delamination we're talking about or the labral tearing, they can progress with time, so rather than getting better, they'll get worse. But the key concept is this is a mechanical problem. Something is hitting something that's not supposed to be in contact. As a result of that, things are being torn that are not supposed to be torn. It's very hard to do physical therapy to solve that sort of mechanical issue. So unfortunately, oftentimes, this is not sufficient. So what do? Well, then we have to go toward operative management. Our goals there are to improve the clearance of hip motion so there's no longer pinching or impingement as the hip goes through these motions. We alleviate the femoral abutment, which could be on the femur side or the cup side, and then we remove or repair the torn and unstable tissue, and that could be the labral tear or the chondral delamination. what oftentimes happens is as a result of all this going on in the hip, the whole hip gets inflamed and red and very unhappy, and that's called synovitis. Itis means inflammation of, synovium is the lining of a joint, so synovitis is inflammation of a joint. And what we can do is we can remove that with a cautery device to make the hip less painful. So how do we go about this? I've already alluded that my personal belief is that we can do this very well through an arthroscope, through a few poke hole incisions. In Europe, especially in Switzerland, they still tend to favor the open approach here, and that is an option that's available to surgeons and patients. I and many of my American colleagues believe you can do just as complete a job and just as accurate a job through the arthroscope, and I prefer it for that reason, for the reason that it's a much smaller incision, the recovery is easier, you don't have to actually dislocate the hip, which you do have to do here, and patients seem to be happier with that. So let's talk about hip arthroscopy. While you don't dislocate the joint, you do have to distract it a little bit because the ball usually sits flush up against the socket and there's no room to work in there. So we have to pull on the limb a little bit to distract it to give us some working room here. And this just shows that synovitis. This was a gentleman who was extremely unhappy and was having even difficulty walking because his hip was so painful. And you can see, or I should say you can't see, much here because the whole hip is inflamed and it's got all this old chronic synovitis sitting here, and it just looks like a very unhappy scene. So once we clean that up, we can get a look at actually what's going on. So we cleaned up the synovitis. You can see a cleft here. I drew an arrow in to point it. That's the labral tear. And this little probe we see here is actually pulling and feeling the labrum to confirm that there is a tear there and to see how unstable it is. Now this was a gentleman who not only had a labral tear but had too much of the cup there, so we had to trim some of that away. So what our move is now is we get some biters, we get some shaving devices, we remove all the torn labrum, and then we take down the extra bone to create a nice clean edge that would be the appropriate size for the cup this person should have, rather than the excessively sized cup that he had before that was causing the impingement. So this is what it looks like when we're all done. You can see a nice clean rim here, and there's no longer any unstable tissue there, and that's the femoral head you can see just peeking into view over there. Now we're actually going to show you a little video that will help you understand how we got from picture A to picture B here. Okay, so you can see all the torn tissue. It's all frayed, very unhappy, not the way a labrum is supposed to look. And we come in with biting devices initially, which you see here, to remove that torn and frayed tissue. That creates some loose fragments that we take out with a shaving device, which we do later in the procedure. And you can see here we're starting to get down to some stable tissue underneath there. But we continue with this process until it's adequately cleaned up. And then we move on to another part of the joint where we found some synovitic red tissue here. And this is a cautery device. You can see I'd already been doing it for a little while, and you can see some of the tissue had been cauterized and is no longer as red as it was before. And then we continue that up and try to minimize the synovitis that's there. So moving back here. Okay. Now, in some rare occasions, not rare, but in certain circumstances, the labrum isn't torn that badly, and it's able to be repaired. And in the right tear with the right demographic patient, we can do a labral repair rather than debriding or trimming the labrum out. And you see that here with some stitches. Another technology I'd like to talk about is the concept of microfracture. This is something that we do in the knee, but it's also been applied to the hip. Now, you remember before when I was talking about the chondral delamination with the carpet coming off the floorboard? If you have something unstable like that, and it's the source of the patient's pain, unfortunately, what we have to do is remove that. We don't have the technology to put some glue between the cartilage and the bone and seal it back down, and there's no stitch that works well to go sew the cartilage back to the bone. It just doesn't work, and the cartilage that's peeled up is unhealthy anyway and likely wouldn't do well in the long run. So we have to trim that damaged cartilage off. If it's only a small area, that's not such a big deal. As long as you get rid of the unstable, pain-producing cartilage, that's okay. However, in some patients, and I'm going to show you a video of one that I had done recently where it was more of a significant portion of the cup, you like not to leave someone with that much exposed bone in the hip joint. Luckily, nature has a way of growing cartilage where there was exposed bone. What you do is you poke some holes in the bone that causes bleeding. Once you turn the flow off on the surgery, you see bleeding there. And what that does is it creates a blood clot in that area that over time turns into cartilage. Now, it doesn't turn into the kind of cartilage we had when we were all born that was in the joint. It's not that good, but it's better than bone. One of my old professors used to say that, and probably still does say, that if you have just exposed bone there and cartilage on the ball, it's like having ice on cement. It'll glide on there, but it's going to be a bumpy road. What we started with before there were any hip problems was ice on ice, which is fantastic. That glides really nicely. But what we can achieve if we, in fact, have a successful microfracture where cartilage will grow in here, it's called fibrocartilage when it grows in, it's something like ice on grass, which is better than cement, but not as good as ice on ice, but it's the best we can do, and patients actually do very well. You can see a study here by a professor down in Tennessee who's done a lot of this, has almost 90% success rate when he watched patients for at least 2 years. So patients are pretty happy with that. Another procedure that we can do is remove that bump. I've been alluding to it a lot, and you can see here, you see that little hump there? It's kind of outpouching, and we've removed that hump. That's called a femoral osteoplasty, when you remove the bumper hump on the femur. These are some more generic pictures showing how that works. This would be the bump before, and then you can kind of turn it from a convexity to a concavity. And if you take a CAT scan before and after, this was a patient that had all these scans done for the purposes of research and teaching. You have this bump here beforehand, and afterwards it's trimmed down to be a concavity there. And that's a normal looking hip now. That's what you like to see. So let's show you a slightly longer video that goes through some of this. And this is actually some very, very exciting footage, I think. This is going to really show you what I mean about the unstable cartilage. Look at that just peeling back there. That's supposed to be sealed down. And what I'd like to point out is not only is it this part that's injured, which is the worst, but it ripples all the way back to here. I'm going to back it up a little bit to show you that again. See how I'm probing it and pushing on it here, but you see the ripples going all the way back to this portion? I'll do it one more time for you. All right. See that rippling over there? That shouldn't be there. What that means is that you started to get delamination here on the edge of your room, if you will, with the carpeting, and it started to come off, and it went all the way to the central portion. Here I am starting to take some of the cartilage off, and I'm probing it again with this, and I'm seeing it's still moving here. And that means that that's still unstable. And if we ended at this point, this hangnail, if you will, would continue, I believe, to progress, and we want to get it back to a stable rim. So that's what we've done here. Now I'm pushing on it, it's not going anywhere. And we're measuring. This looks huge. That's about 1 centimeter in size by a couple centimeters in length. And this is me now with one of the picks, or the microfracture awls, producing the holes in the bone. And after you turn the flow off and the pressure goes down, the blood oozes out, and will hopefully fill up the area and create that new fibrocartilage there to grow in the new cartilage to make this like an ice on grass rather than an ice on cement kind of scenario. And you see the holes there, and we'll continue to make some more. This is a last little picture of one of the bump removals. You can see we've removed the bone, and it now has a nice concavity, whereas pictures before would have shown a convexity there. Hopefully that was somewhat clear. I know you all don't look at hip surgery videos every day, but hopefully it made sense. So outcomes, this is important. And this is why it's good to be giving this talk right now. If I had given this talk a few years ago, I could have discussed what these new diagnoses are. We think we're doing the right thing. We have some new treatments now that we have the technology to do. And my patients tell me they're doing well, but we don't have a scientific study to really support that. But starting back in 2004, we got our early results back that looked to be very good. That was confirmed in 2006. And then in 2007, we started getting our really high quality data where we had had professional athletes with this surgery, 93% of which were able to return to play. And of all comers, almost 80% remained active a year and a half after surgery. The most important follow-up just came out a few months ago, and this is 10-year follow-up from that professor in Tennessee that I alluded to before. And he followed 50 patients for at least 10 years. And there's something called a hip score, which orthopedic surgeons talk about all the time, but basically your hip can be from 0 to 100. Those are the ranges. And they improved 25 points. So that's like going from a C to an A. That's pretty good. And they maintained that over 10 years. And data like this really makes practitioners feel good because we feel that, yes, we can offer patients something that we have good evidence will not only help them in the short term, but help them in the long term as well. And it's also nice for patients because then you can proceed with some of this treatment with a little bit more confidence and knowledge about what to expect. One of the themes that did go throughout these studies is that in folks that had arthritis, the results aren't as good. Arthritis is when you start to get global cartilage injury. So rather than a specific area starting to peel off, an area of carpet starting to peel off, arthritis would be if the carpeting in the whole room was just starting to wear out and it was time to bring new carpet in. Fortunately, you can't do that in the hip. You have to either live with it or get a hip replacement. And in patients like that, arthroscopy would not be the way to go. So just a final slide here. I think we've talked a fair bit about the femoroacetabular impingement and the labral tears and the chondral delamination and the exciting technologies that we have to treat that now. And that's where the bulk of the talk is. I just wanted to briefly mention snapping hip, which the real word for is coxus saltans. And there are two main causes of snapping hip. The IT band, which runs around the outside part of your thigh, which can oftentimes be inflamed and patients get irritation in, can snap. And when that snaps, patients will actually kind of see it snapping over the side of their hip when they move their hip in certain positions. Another tendon that can snap is the iliopsoas tendon, which sits in the front, just over the groin. And that you usually don't see snapping, but patients will oftentimes actually hear it snapping. And sometimes they'll be able to do it in the office, and we'll hear it there as well. Now, the difference with these problems and the ones I mentioned before is these almost universally do well without surgery. Since these issues are dealing with tight tendons that are snapping over bony prominences, it stands to reason that the treatment should be to stretch the tendons and decrease the inflammation in them, and hopefully they'll stretch out, the tension will be less, and we won't have these problems. And that usually works very well. Of course, like in anything, there are some patients that have a really bad case or their inflammation's off the charts or whatnot, and they don't get better, and there are arthroscopic treatments to handle both of these, where basically what you do is you either partially or completely release the tendons to relax them and eliminate the snapping. So in sum, I just wanted to reinforce that this is an exciting time for my colleagues and I as orthopedic surgeons or orthopedic surgeons that specialize in hip arthroscopy because we have a lot to offer our patients. We've got new diagnoses, and thankfully there are effective, minimally invasive treatments that we can employ to help these patients. And I just want to emphasize one more time that I think there are a lot of people out there in the public that have these conditions. They have femoroacetabular impingement, they have labral tears, they have chondral delamination, but they went to see me or one of my colleagues 7 years ago, and they didn't know. We didn't know about these diagnoses, and we weren't able to treat them as a result. So I think there are people out there that if they come back to the doctor, some of them will be able to help now that we have this new information. So thank you very much for your attention. I really appreciate it. Appreciate everyone coming out, and I'm happy to answer any questions that you might have.
Thank you. What about if a person is out of alignment back-wise and they feel that one leg is longer than the other, although it's not, so that leg is always hitting the ground much more and faster and sooner than the other leg, and that's the leg where they have a problem?
Well, you bring up a good point. One of the good points, and I'm going to get to the question directly, but one of the issues is that not only can there be a lot of areas in the hip that are the source of pain, there can be other things near the hip that are the source of pain. It could be the low back. A lot of people have low back pain, and that can radiate into the buttock, and teasing out whether pain is coming from the groin or the hip, or in some patients coming from both, and how much of the pain can we attribute to the hip versus the back that can be complicated. But to answer your question, what you're alluding to is something called an apparent leg length discrepancy. Some people do have one leg or limb, lower limb, that is longer than the other. In reality, that could be for a variety of reasons, and they can have lifts to equalize that or surgeries to correct it. A lot of other folks don't have an actual difference in the length of their limbs, but what they do have is an obliquity or tilting of the pelvis, and what that does is it hikes up one side and puts the other one down and makes it seem as if one leg is longer than the other to the patient. And the treatment for that is typically physical therapy, because there's nothing actually wrong with the bone or the skeleton itself. It's just a matter of correcting the muscles and tendons about the pelvis. Now, the exception to that is if there is a curvature or arthritis or deformity in the back, that can also cause this apparent leg length discrepancy. And if the source of the issue is the back, then treating the hip obviously won't help. It sometimes is true that there can be something called a red herring. Someone could have an ugly-looking X-ray of their back that has a curve to it, and one leg might be longer than the other, but that actually might not be very symptomatic. It might just be there and bothering the patient, and what really is going on is something in the hip that's causing their symptoms. Now, the converse is probably more commonly true, which is when someone has some curvature in the back and some arthritis there and some obliquity of their pelvis that is causing a lot of pain. And some of that pain is referred to the hip area, but isn't actually coming from the hip. So that would be a patient where if we were concerned enough about the hip actually having something wrong, we'd be getting the MRI, we'd be injecting the dye and the numbing medicine, and that patient might say, I know we thought we were looking at this hip, but they injected the numbing medicine in my ball and socket joint, and it didn't change my pain at all. It was all still there. It didn't help one iota. And with data like that, we would say, well, we may have been fooled. This isn't coming from the hip. This is coming from something else like the back, and we just need to treat that. But there's a lot of interplay there. And it's a long-winded answer because it's a complicated problem.
Yes. What if you've been diagnosed with bone spurs on the lower part of your back, till the tailbone? How would that affect the hip and the joints?
When you say lower part of the back, I heard tailbone also. Are you including the lumbar spine in that as the...
The doctor I had just said it was the lower three vertebrae.
Okay, the lower three vertebrae, I suspect he's talking about your lumbar spine, because the lower three vertebrae, technically speaking, are in your little tailbone, which no one really worries about. So what we're talking about here are bone spurs in the lumbar spine. Bone spurs, just like I showed on one of those x-rays early on for hip arthritis that had bone spurs are a sign of arthritis. What basically happens is the body's pretty smart. The body realizes that the joint is painful, it's being overloaded. How can we minimize this? And what it tries to do is grow. It tries to make the joint bigger. It expands out with bone spurs, which for anyone who has an engineering or physics background, you'll appreciate that by increasing the surface area or size of a joint with these bone spurs, you're decreasing the load at any one point because it's distributed, the same amount of load is distributed over a larger area now. So you must have some early arthritis or some moderate arthritis in the low back there. That is unrelated to these sorts of conditions in the hip. However, the same patient can have both issues. You may have both, and then it's one of those diagnostic challenges where we do a lot of physical exam tests, talk to you a lot about what exactly the complaints are, tease things out, and sometimes we do some of the advanced diagnostic maneuvers like the MRI and injection and such to really differentiate things. But we would want to make sure that we treat the one that's causing the problem and don't get fooled and treat one that actually isn't causing your main issues.
I had an MRI of my hip because I had a lot of pain, especially if I stood up or had to raise my right leg at all to clear a cigarette on the sidewalk, basically. And the MRI showed that I have a tear in my gluteus medius. And so I guess the treatment's physical therapy. I started that, but I had to stop because it really made my lower back hurt. So then I guess my options are to have surgery. And I was wondering if are you familiar with that kind of surgery and what sort of results? But I also just want to say, I my neurologist referred me to a chiropractor, which terrified me, but I went, and he uses something called an activator, and over 2 months, the pain and the weakness is like 90% gone. So I don't feel, at first I was feeling, well, I've got to get surgery right away. So I feel like I have a little more time, but I'm wondering what, outcomes you've seen with repairing the gluteus medius.
It's a very sophisticated question. The first thing, and I thank you for it, the first thing I'll say is that I'm not familiar with what an activator is specifically. I don't know all the chiropractic techniques, but if you're feeling 90% better, I wouldn't do anything too aggressive with it, because a lot of these issues are just about how you feel. The gluteus medius can be torn. The gluteus medius is a muscle and tendon on the side, and it's very important because it allows us to bring our leg out to the side. And bring our leg out to the side is something that we may not do very often intentionally, but that same muscle gets used every time we walk. Because if you don't have a gluteus medius, what will happen is when you walk, because every time you walk, you're on one leg for a good part of the gait, you'll sag. You basically need to tension in here when you're on one leg so you don't fall over. And that's the gluteus medius that does that. Gluteus medius, the gluteus medius has been analogized to the rotator cuff of the hip. However, it's an extremely uncommon surgery that's done and has only been reported in the last couple years. So, like I spoke about before, Columbus discovered the Americas, Lewis and Clark went around and looked at everything. Gluteus medius repairs, they might represent, Baja California. We just got there and are just looking at it, and it's in its infancy. And we don't have long-term results on gluteus medius repairs yet. There's a surgeon in New York that has been one of the leaders in that, and he has some short-term data that shows some hope, but it's very early. I'm also actually, just as an aside, impressed that the radiologist noted that, because a lot of times radiologists and even surgeons aren't aware of that as a possible source of injury and don't look for it. So that's good they picked up on it. Like everything, just because something is shown as being abnormal on the MRI doesn't necessarily mean that it's the reason you're having pain. You may have had a gluteus medius tear in the past that didn't bother you. They might have found it on the MRI. Your pain might have been from something else and gotten better. It's also possible that the gluteus medius was in fact the cause of your pain. But if you're feeling well now, I'd be hard-pressed to advocate something aggressive.
I'd just like to find out, if you have the procedure, basic procedure of the head, how long is the procedure taking, and then how long will it heal? And how long is the stitches that you have to open? I'd just like to find out.
Sure. So how long the procedure, how long the stitches, and was there a third one?
And how long will you heal? How
long
long
do you
will it
heal?
heal?
Okay.
How long is the procedure, and how long is the stitches?
The procedure can vary because there's a lot of things we can add on to it. It's like when you buy a car, you can get extras, And if you just do a basic hip arthroscopy, it typically takes a couple hours, but they can take up to 3 or more hours. They can take up to 4 hours if you do a lot of work in there. It's not like a knee arthroscopy that you typically do in a half hour or an hour, hour and a half. There's a lot of work being done. Hip arthroscopies take more time. The incisions are small, a centimeter, very, very small incisions, and they just have a couple stitches in each. And the recovery or healing, a lot of patients tell me that even a couple days after surgery, they may feel better than they did beforehand if they had a lot of pain before. What I tell patients is you'll keep getting better until 8 months or more after surgery. A lot of times here, we're doing things like shaving bone. That's a lot of work. That's not usually done in an arthroscopic procedure. So even though it's small incisions, a lot's going on the inside. And if someone has one of those more advanced procedures where we're shaving bone on the femur, shaving bone on the cup, maybe doing a microfracture as well and having cartilage heal, I usually tell them that you'll feel about 75–80% of what you're going to get 2 months after surgery, but you'll continue to improve over the next 6 months to get that last little bit. Problem.
Hello. Yeah, I've seen something being advertised in the local papers. It's called I think it's a cold laser or the low intensity laser, and they claim it's beneficial for hip discomfort as well as many other things. Do you think any value in that, in your opinion?
Well, I want to make sure we're talking about the same thing. This is a low intensity laser, and who is offering that?
Well, I've seen the big ads in the Argus and local
Okay.
newspapers. It's like a full page ad.
It's not a treatment that I'm familiar with. Oftentimes there are non-physician practitioners that treat these complaints, chiropractors or therapists or whatever, and they have somewhat different treatments. My thought is that the laser isn't going to get down to your hip joint, and if it is, it means it's burning a hole in your skin en route to it. So I hear that, and without knowing the story, I get very skeptical about the true validity of that treatment. I would need to see some real evidence scientifically showing it was good to kind of take me away from that biased perspective where I'm not very confident that it's doing anything other than a placebo effect. That's my bias going in.
I was wondering, is there a way to tell the difference between the pain that's IT band kind of pain versus the hip pain that you're talking about with the impingement? Because I've had treatment for IT band and been fairly unhappy with the results. And I was wondering, should I be looking into this as an alternative? Because the IT band treatments, I've had physical therapy, I've had the cortisone shots. And then I also did try chiropractic with the, whatever that device is called, and had some relief from that that lasted 6 months or more, but now the pain is back. So should I be looking at more IT band treatment or looking into possibly a different diagnosis?
Well, I think that the possibility always exists that an initial diagnosis was not correct. That's something all physicians think about when we have a patient who hasn't gotten better. We start back from the first step and say maybe our initial assumption that the diagnosis is X or Y may not be true. Typically, differentiating IT band pain from pain coming from the ball and socket is straightforward. There are some cases where it's a little bit blurry. But IT band pain is on the outside part of the hip. Oftentimes there's tenderness right over a specific point called the greater trochanter. And sometimes there is the feeling of snapping, although there doesn't have to be. Also, if we examine a patient and put them on the sides, we can examine how tight the IT band is on the right compared to the left. And if the symptomatic side is tighter, that adds weight to our supposition that, in fact, the IT band is symptomatic. On the flip side of that, there are other tests we do that are specifically meant to test that ball and socket and shouldn't really come out as positive if the pain is coming from the IT band. So depending on whether the ball and socket tests are positive or the IT band tests are positive, that helps us decide where it's coming from. But it's certainly worth getting looked at. If you're having pain at this point still, it's worth getting it looked at regardless. Because whether it's IT band pain or hip joint pain, there may be treatments in either arena that would help you.
You've talked about various diagnostic techniques that you described here to establish the source of the hip problem. How widely available are those? Are those state-of-the-art? Are they confined to just a few practicing physicians like yourself? Or are these now state-of-the-art that are widely available?
That's a good question. What I would say is that they are widely available, but they are not widely made use of. The advanced imaging that we're talking about is an MRI, which we have all over the place here, but what you need is to go to an MRI machine that has a radiologist there, which there's one right around the corner in the building here, for example, and the radiologist injects the dye and the numbing medicine in there. It's relatively easy to find a facility that can provide that service. What I think the greater challenge is educating our physicians about this. Orthopedic surgeons, we would expect, are the folks most informed about this. And even in my profession, this is a new appreciation, and the word is still getting out. And I think it's the minority of orthopedic surgeons that are aware of this phenomenon and making the diagnosis. I think that'll change in the coming years. So while getting the testing and the work done is straightforward, getting on the right track to have that testing sometimes can be a challenge.
Well, that's precisely why I asked the question, because I've had an evaluation of what has not been chronic and only recently you simply have a hip problem, and it's not specific at all. And the only comment was, well, it looks like you're going to need a hip replacement, which is, to me, a tremendous overkill, especially after hearing your presentation, that one needs to establish just what the source of the problem is before you embark on such a dramatic fix.
This is the reason I wanted to give this talk. And now it may be that maybe your problem, I haven't seen your x-rays, maybe you have really bad arthritis, I don't know. The truth is, for arthritis, a hip replacement is an amazingly successful surgery. It's one of the most successful surgeries, period. However, even a surgeon that does hip replacements will tell you we only want to do that surgery when it's needed because there is arthritis. So the possibility certainly exists that you have one of these conditions, and it may not be known at this point.
Hi, I was just wondering, do inflamed bone or joint tissues affect one's cardiovascular health?
That's interesting because we know inflammation is part of cardiac disease now. We didn't really appreciate that. Even when I went to medical school, they weren't talking as much about that. But I think the answer is no. The joints are very interesting in that they're somewhat sequestered from the rest of the body. And what's going on in the joint typically kind of stays in the joint and doesn't go elsewhere. So you might have a very inflamed, angry joint, but outside of that, things are pretty good. It's like the Berlin Wall around there. Nothing really gets in, nothing gets out. And the inflammation in the hip joint need not translate to inflammation in the cardiac system, and you shouldn't have the risk associated with that.
I was also wondering, there's a blood test. It's called C-reactive protein test. And would that be elevated with a joint or bone inflammation?
It shouldn't be. And while I use the word inflammation, I was using it more in kind of a local context where there was some mechanical issue, like a tear or impingement, that was leading to secondary inflammation. If someone has a condition like rheumatoid arthritis or an infection, something that's more systemic, then you'll see the CRP elevated in that setting also. And rheumatoid arthritis certainly, or an infection, certainly can be a cause of hip pain. So in that setting you can get that combination. But for these things, it shouldn't be.
Hi, doctor. I'm 58 years old, and I'm suffering from diabetes. On the title of this class, it says, in the young and middle-aged adult, what would be the complications if I go for this surgery?
Well, surgery has risks with anyone. A diabetic specifically has some increased risk of infection because the immune system is not as active in diabetes. And infection risk is always higher with any surgery with a diabetic. That being said, a 58-year-old diabetic with the right diagnosis and the reason for the surgery is a very acceptable candidate, and that wouldn't get in the way. What we do with any of our patients that have any medical problems is we have a patient see their medical doctor prior to surgery after we've decided to go down that route. And the medical doctor makes sure that the heart is okay and the lungs are okay and that the diabetes is in check and that everything is optimized so that the car is running as well as possible going into surgery to make things go smoothly. Trying to keep sugars in control, etc.
Hi. When the worst pain is when you first stand or get up in the middle of the night, you've rolled on that side, why is it that eventually as you walk it out, it seems to subside?
No one really knows the answer to that. There are a couple diagnoses that are classic for that pattern. One of them actually is plantar fasciitis, which is a cause of heel pain that's fairly common. People will be really debilitated those first few steps getting out of bed, and then all of a sudden it'll get a little better, and it'll be more of a nag throughout the rest of the day. We don't really know why. I could conjecture that it has something to do with things not having moved and tightening up over the course of the evening. And once you start getting it moving again and stretching it out, be it the plantar fascia or whatever you have in your hip, perhaps a tendon issue or whatnot, it slowly gets going, the joint gets lubed up, and the pain decreases. But like I said, that's not an answer. It's a conjecture.
Generally speaking, if you go to a pharmacist, you'll see several over-the-counter products that are directed toward many of the topics you've commented about. Is there a recommended product in your mind for pain relief? I've had people tell me Tylenol and Condotrin and a few of the others that are pretty elaborate names.
Right. You touch on a theme here that other folks have talked about as well, which, and I'll get to your specific question, but it deals with the non-allopathic medical care, chiropractic care, herbal remedies, massage, etc. Tylenol, of course, falls under the category of allopathic regular medical care, and that's something we use for our patients. Tylenol is not actually an anti-inflammatory, so if inflammation is part of the issue, it won't actually help with that. Something like ibuprofen or Motrin might. Glucosamine and chondroitin had for a period of time, and still continues to be to a certain extent, kind of a special nutraceutical, as we call it. It's a pharmaceutical that's kind of half vitamin, half pharmaceutical, and you get it at the health stores, where there was actually some scientific evidence suggesting that the glucosamine and chondroitin could decrease joint pain in some patients. There have been some studies since then that suggest it may be a little less effective than we thought it was. What I typically tell patients when it comes to these things is, as they can get expensive if you take them for long periods of time, don't take them unless they're really helping. But if they're helping you, I have no problem with you taking them. We don't have good scientific studies for a lot of these nutraceuticals, pharmacy-type, health store medications, because they're not by pharmaceutical companies, and they don't create those kind of scientific studies where they do the rigorous statistics and it's set up in a scientific manner. So no one on the planet really knows how much they work. A lot of patients take them and say they get relief, and it may be because they're actually making the patient better. The question is, how much of that is placebo effect and how much of it is due to the medication? That's where it gets difficult to tell without a scientific study.
There's one gentleman I know that has several joint and muscle discomforts, and he has an awkward walk as the direct result of that. And he sent to Canada to get some pharmaceutical product that was over the counter in Canada, but not in our country. And I can't recall the name of it, but do you know of something of that nature?
I don't know specifically what medication you're talking about. What I do know is that what medicines require a prescription are country specific. I've been traveling overseas and popped into pharmacies just out of interest to see what you can buy there without a prescription. And if you go to the right country, it's pretty much any medication. The concept of a prescription really is only just the doctor telling you what you need. It's not a mandatory piece of paper to have. Our country has extremely conservative policies when it comes to prescription drugs and medicine in general. And I mentioned here today that a lot of this started in Europe with surgeons doing things. That's not an accident. And there are a couple other lectures I could give you as well about other things in orthopedics that started in Europe too, because they have a little bit more flexibility and they're less strict in terms of the regulations surrounding medications and new surgical procedures, etc. Our FDA is quite protective of the American populace, and I can't complain about that. They're looking out for our safety, but sometimes it does lead to the situation like you talked about, where you can go over the border and get a medication without a prescription, which here would require one.
Let's thank Dr. Nord.